Good evening, everyone, and welcome again for this webinar series of ISCCM. And today we have a webinar on artificial intelligence and its role in critical care. We all know artificial intelligence is taking over the world in all fields and growing more rapidly in critical care. And it has great potential to actually improve the field as well as to improve patient outcomes. For this webinar, we have Dr. Prashant Nasa from UK, who is the mentor, and he has chosen the topics which are divided for the webinar. So Dr. Prashant, first a word from you to tell us why did you choose this series of topics and what do you feel about artificial intelligence in critical care?
Thank you, Dr. Gunjan. I think we all understand the role of artificial intelligence and how artificial intelligence is going to impact not just medicine, not just healthcare, but almost every field which we are looking and working across. So probably next decade or so, artificial intelligence will revolutionize the way we work, the way we roam around, and of course, the way we practice in healthcare. And working in critical care medicine, where there are a lot of things which need to be integrated and need to be considered while managing a critically ill patient, I believe artificial intelligence has a big role to play, where they may supplement the way we treat our patients and going to help in integrating various sources of information which we use to manage critically ill patients. So I believe not just the predictive artificial intelligence, which we are seeing coming up in intensive care units very rapidly, but also various other aspects of machine learning and deep neural networks will help us probably in next few years to decade. And that's the reason I believe we should understand how to use this new technology for our help, and more importantly, how to embrace this technology rather than to be afraid of this one.
Thank you, Dr. Prashant. So to begin, we have Dr. Shweta Chandan Khede. She is a senior consultant at Care Hospital, Hyderabad. And she will take us to the first talk about how artificial intelligence can help us support clinical decision-making in the ICU and the early warning systems in the ICU.
Good evening, everyone. Thank you, Gunjan Madam, for the introduction. So today we are going to dive into a very interesting and medicine, that is the addition of artificial intelligence into critical decision making and the early warning systems. So we all know that ICU is a place where patients are often very sick and need continuous monitoring, and then it becomes very difficult for the medical staff to assimilate all the data and take quick decisions. So, and we also know that the ICU is a very complex situation where there are high stakes, and therefore we need some tools which can improve the decision making and enhance the patient outcomes and also ease the workload of the medical staff. So this is where we have AI which can be very helpful to us. So in our today's topic, we will discuss how AI is being integrated into the clinical workflows in the ICU, the technologies and the algorithms which are involved, as well as the real world application of AI. However, our goal is not just to understand what are the potential benefits of AI in the ICU, but also how safe, effective, and ethically sound these algorithms or technologies are for our patients. So we have evolved from like apes, and once upon a time, our ancestors, the Homo sapiens, were busy hunting and figuring out how to light fire. As the time went on, we became smarter, and fast forward, we invented the wheel, then the machine, which could do the work faster, and then we invented the computers. And now we are in the age of artificial intelligence, where computers can outthink us in many tasks. So from the cave paintings to the clever algorithms, human intelligence have come a long way. So let's see the historical journey of artificial intelligence. So this journey is quite fascinating. This image presents the timeline of the significant milestones in the history of AI. So it basically started from Alan Turing's work on cracking the Enigma code, and then the Turing test paving the way for artificial intelligence. Then in 1955, John McCarthy, the father of AI, coined the terminology artificial intelligence. Then the early chatbots like Eliza, Alice evolved into more advanced AI, as seen in the Deep Blue Sea chess victory. In 1998, Kismet, a socially intelligent robot, expressed emotions. In 2008, voice recognition technology improved. In 2011, IBM Watson won the Jeopardy, and it showed that AI's language skills are better. In 2011 and 2014, we saw the emergence of Siri and Alexa, who offer robust voice-activated assistants. Then in 2016, we saw the birth of Sophia, a humanoid robot known for her human-like appearance. So OpenAI was then founded in 2015 by a group of technology entrepreneurs and researchers, including Elon Musk. In 2020, we have ChatGPT, that is the generative pre-trained transformer models, which became very powerful tool for automated conversations and content creation. And now we have ChatGPT 4, which was released in March 2024. Perplexity AI was found in 2022. It's a free AI-powered answer engine that provides accurate, trusted, and real-time answers to any question. And I am very proud to tell that one of the founder was an Indian, Mr. Arvind Srinivas. Then comes the Google Gemini, which was introduced in early 2024, and it's a large language model developed by Google AI. So overall, the evolution of AI has marked by significant progress. So let's see a small.
52 years old. Your height is 6 feet 2 inches, and your weight is 197.6 pounds.
Yeah, genius.
You have 2 diagnoses and 1 free treatment today. Would you like to proceed with the first diagnosis? Please confirm co-payment of 126,356 bitcoins to proceed.
Okay. Yes.
Payment received. Diagnosis: capillary dilation within the bronchial tubes. Would you like to proceed with treatment for capillary dilation within the bronchial tubes?
Yeah, why not? It's free.
Initiating treatment.
Hey, what is it? What is this? Hey, what?
Treatment complete.
So this video that once seemed to be like a fiction has now become a reality, and thanks to the advancements in AI. So AI is lately gaining a lot of importance in ICU. We see that most of the complications in the ICU are because of the human errors, such as forgetfulness, inattention, and inexperience, and they are more frequent and severe than the technical failures. So, and also ICU has a vast amount of data from each patient, which can be overwhelming, especially when dealing with patients who experience higher rates of complication and longer stays in the ICU. So in such scenarios, detecting complications or symptoms can be particularly challenging for the medical staff. So AI is becoming more promising in ICU because it quickly processes the complex data and aids the doctors in faster and more accurate diagnosis. And it also predicts the complication, thus it can help us in improving the outcome. It also reduces the stress on the medical staff with the decision support, and it can give personalized treatment plans and also optimize the resource management. So what basically is AI in context to healthcare? So it's basically the use of advanced algorithms and softwares which mimic the human cognition in analysis, interpretation, and comprehension of the complex data. So by using the large data sheets, the AI can improve decision making, streamline healthcare delivery, and boost the patient outcomes. So then there are some clinical decision support systems, which are tools that assist the clinicians by analyzing the patient data and recommending the diagnosis, the treatment, and care plans. These systems can help reduce the errors, and they ensure the adherence to the clinical guidelines, improve the patient outcomes by providing evidence-based recommendations. So these AI enhanced CDSS systems can further analyze complex data such as the imaging as well as the genetic information and give more accurate and personalized suggestions. Then the early warning systems are tools in the ICU to detect the early signs of patient deterioration. These systems monitor the vital signs and other clinical parameters to identify patients at risk of adverse events such as sepsis, cardiac arrest, respiratory failure. So by utilizing these AI algorithms, the early warning systems can improve the accuracy and speed of these predictions and thus allowing timely intervention and reducing the risk of complications. So there are many terminologies in artificial intelligence. Basically, AI is a broad concept. It's like machine performs tasks that actually needs human intelligence. So it has many subsets like machine learning, natural language processing, and deep learning. So these are all interconnected fields which are built on each other. So the machine learning is a method within the AI where machine learns from the data to make predictions or decisions. The natural language processing is a branch of AI, and that understands and works with the human language. And the deep learning is a type of machine learning that uses the complex neural networks to analyze large amount of data, especially for tasks like image and speech recognition. Then these artificial intelligence systems in healthcare have a specific pattern. Such system starts with the collection of large amount of data, and on this data, the machine learning algorithms are employed and to gain information. So this information is then used to generate a useful output to solve a well-defined problem in the medical system. So let's see how these AI technologies can be useful in the ICU. So machine learning learns from the past patient data to make predictions about the future outcomes. For example, by analyzing the data such as medical history and the test results, the machine learning can estimate a new patient's recovery chances based on the pattern found in the previous case. Then the natural language processing helps by reading and organizing the information from the doctor's notes, such as the symptoms and treatments, and it makes it easier to manage the patient records and improve the care. Then the deep learning employs neural networks, and it can identify the patterns like tumors or fractures in the X-rays or CT scan, and thus help the doctor make more accurate diagnosis. So to simplify, we have two types of AI which can be used in healthcare. One is the predictive AI and the second is the actionable AI. So predictive AI generally focuses on the predicting the future of the patient outcomes or events. So it's like looking into the future of the patient and anticipating what can happen. For example, predictive AI can be used to predict the mortality risk or the onset of sepsis in the patient. Whereas the actionable AI goes beyond and suggests specific actions to be taken or based on those predictions. It's not just like seeing in the future, but also knowing what to do about it. For example, actionable AI might recommend optimal IV fluid volumes or vasopressor dosing for a patient with septic shock. So the predictive AI simply predicts an outcome, while the actionable AI involves understanding the cause and effect relationship between different factors. So in ICU, both this predictive as well as actionable AI have the potential to improve the patient care by providing the early warning and guiding the treatment decisions. So what are the various applications of AI in critical care? So it can be used for disease identification. We all know identifying the root cause of a clinical deterioration is challenging due to subtle disease progression or overlapping of the condition. For example, pulmonary infiltrates might not always indicate indicate excess fluid. So AI can help us by providing more accurate diagnosis through advanced text and image analysis. Then it can be helpful for predicting the disease progression. We all know that disease progression is vital for critically ill patient, because delays in recognizing the instability can be very fatal. So the early warning systems help identify patients at risk of deterioration, enable timely intervention. So there are AI models which could predict patient deterioration 90 minutes before the actual crisis. Then it can also be used for disease phenotyping. We all know critical illness is complex and can present in various ways that can complicate the recovery. So AI has ability to recognize the patterns in complex data and can help identify the unique patient profile. Then it can also help us in guiding the clinical decision. In critical care, one size fits all solution does not work, because it's a complex, there are various complex issues. So AI can help us create individualized treatment by learning from the different variables and the outcomes. So this slide shows us, demonstrates how AI can enable early detection of the disease progression. So by identifying signs of illness before they become severe, clinicians can intervene early, potentially improving the patient outcomes. The green line represents the early detection enabled by AI, while the yellow dotted line represents the traditional detection methods. The image suggests that AI can help manage the critically ill patients more effectively by providing early warning and allowing for more timely interventions. So there are many benefits of AI in the ICU setting. So it can potentially revolutionize the patient care in ICU by improving the patient outcomes, by early detection, accurate diagnosis, optimizing the treatment. It can enhance the efficacy by automated tasks, resource optimization, and reduction of errors. It can improve the decision making by data-driven insights, risk assessments, and personalized care plans. So numerous studies have been conducted in ICU to compare the AI and traditional methods to predict conditions such as sepsis, acute kidney injury, respiratory failure, cardiac arrest, and patient deterioration. So how does AI do this? So AI builds some models which processes the large data sets like extensive electronic health records, lab results, vital signs, and clinical notes, and it's seen that it does this thing more comprehensively than the traditional method. It also helps us by real-time monitoring and thus detects the early warning signs and might predict about the sepsis, which can be missed by traditional methods. By pattern recognition, it can identify complex patterns in the data, and it is better than the traditional methods. It also uses the unstructured data like the clinical notes, and thereby it improves accuracy by reducing the false negative rates and improving the false negative as well as false positive rates as compared to the traditional methods. So there are many studies. We'll see a few of the studies. So there was one study published in Nature which developed a deep learning model that predicted sepsis onset early than the SOFA and the SIRS criteria. This AI model analyzed almost 65,000 patient records and was able to predict sepsis 3 to 4 hours before it would have been detected using the SOFA or SIRS criteria. So they compared the performance of a software known as the SERA AI algorithm with standard clinical practices and predictive traditional scoring systems like SIRS, SOFA, QSOFA, MUSE, which have the area under the curve ranging from 0.5 to 0.8 and varying true positive rates and false positive rates. It was seen that the SERA algorithm achieved a higher prediction accuracy than the hospital physicians and traditional scoring methods, and it detected sepsis earlier, and also it detected sepsis more times. For example, it detected sepsis 32 times more than the traditional methods, and it detected sepsis almost 48 hours before the onset, and it had a better true positive rate, and there was a reduction of false positive rate by almost 17%. So this all showed that the AI outperformed physician and thus provided more timely alerts and potential for effective and early intervention. Then there are so many other studies. For example, Henry et al. They developed a true score, a machine learning based early warning score for predicting septic shock in real time. The true score outperformed traditional scoring system like the SIRS and SOFA and detecting septic shock early and allowing for early interventions. Similarly, other studies created some machine learning models for early sepsis predictions in ICU and found the similar results. Then Shashi Kumar et al. Utilized a machine learning algorithm to predict sepsis using dynamic blood pressure and heart rate data. The AI algorithm outperformed the SOFA score by predicting sepsis early and more accurately, and thus improving early warning and patient outcomes. So there are multiple studies, and they have all shown that the AI models have been better than the traditional scoring methods like SOFA and SIRS in predicting the sepsis and other outcomes in patients early, and thus improving the patient outcomes by the timely management. So there is something called Glass AI, which uses the data and technology to make healthcare better. So it has two versions. One is the basic version and the other is the paid version. So you just have to input the data, whatever data of the patient is available. For example, the patient demographic, the clinical history, comorbidities, and lab results. So based on this information, the system provides various differential diagnosis as well as suggests a plan for action. So this is very useful in ICU patients with longer stay in the ICU, where we find it difficult, sometimes challenging to connect the biomarker with the patient's clinical deterioration. So we absolutely love AI in healthcare. It's like having a super smart assistant who never sleeps. But let's not forget, it's also the assistant who might accidentally prescribe pizza in place of penicillin. So it's amazing, but a little oversight can turn artificial intelligence into artificial insanity pretty quickly. So Elon Musk made a very bold statement that AI possesses greater threat to humanity than the nuclear weapons. So why so? So AI is like a black box. So what is black box? Here we know what is the input, that is whatever data is fed in the AI, and we know what is the output, that is the results or the decision it produces. But the process that transforms this input into the output is hidden and not easily understood by the healthcare workers. So this lack of transparency can make it difficult to know how the AI has arrived to the conclusion, which can be a key issue in the healthcare. So there are many which can be faced with is the data privacy and security. You know that healthcare possesses sensitive patient information, and there is always a risk of financial frauds. Then integration with existing system is not always straightforward. Different hospitals and clinicians use various electronic health record systems, which can make integration tricky. The older system might not even support the new AI technologies.
We'll be covering this
Then,
in the challenges. Shweta, we'll be covering this in the next topic.
Yes,
I think we need to quickly skip this. Maybe we'll this detail will be discussed.
Yeah,
in the
this
next
last slide. Yeah. So there are other ethical problems also, which will be discussed in the next session. So we recently saw that Microsoft faced a global hiccup known as the blue screen death. This glitch caused widespread disruption by halting the systems and interrupting the services. So just like how these tech crashes can be inconvenient, a similar issue with AI in healthcare could disrupt critical care patient care and lead to serious consequences. It can lead to the loss of important patient data, affecting the care. And there can be sudden increase in the manual workload, increasing the error risk and slowing down the care. Thus, AI failure can cause incorrect diagnosis and treatment and risking the patient life. So lastly, we have come a long way from early humans to tech savvy folks, and now it seems we have handed all our thinking over to AI. It's like our brain is taking the vacation while the AI does all the thinking. So too much of reliance on AI will not prove good for our brains. So AI is a good servant, but it can quickly become a bad master if we are not careful. While it helps us with tasks and decisions, letting it take control of too much can lead to problems. So it's important to use AI wisely and not let it replace our own judgment and responsibility. We should use it for our learning and progress. AI is a powerful tool, and it can help us getting the information on medical topics, guidelines, and recent researches. Just ask a question and it will give you an answer. It's great for creating patient education material, drafting explanations, and making complex concepts very easy to understand. Beyond that, it can also be used to spark ideas for research, case presentations, and discussion with the colleagues. So it helps in identifying the gaps in the knowledge and offer a fresh perspective. Plus, it can handle clerical tasks like summarizing the literature, drafting mails, and discharge summaries so that you can focus more on the health care of the patient. So this is my perspective. That's all from my side. If you have any question, you can ask it to ChatGPT.
Thank you so much, Shweta. I know it is very difficult to cover the uses of AI in just 15 minutes, and it was quite unfair to give you such a small time. But yes, you did give us some gist about the next topic, and we'll quickly go to the next topic, which is while we have opportunities with AI, we also have a lot of challenges that we have to face. So Dr. Abhishek Prajapati, who is a consultant of critical care as well as chest medicine from Karamsad Shri Krishna Hospital, will take us through the next topic of ethical challenges in AI. Please share your slides, Abhishek. If you have any questions, please put it in your chat box. We will take up the questions at the end. We can't hear you, Dr. Abhishek. Are you there?
Abhishek, we can't hear you.
I believe he can't hear us.
Abhishek, we can't hear
Bharat, can you
I think
give him a call directly?
Yeah. I think he has a network issue.
So we are calling.
Yeah.
Maybe you can switch off your video, Abhishek, so that the network can be better.
Yeah, that will be better, Abhishek. Please rejoin if you can hear us.
Sorry for this glitch. Before he joins again and we start, maybe we can have one or two questions if they are there. There are no questions as of now. So maybe we can have some few words from the moderator who's joined us to speak about AI. What is his view about the whole topic?
Thank you for pitching me early, Gunjan. I mean, it's always a pleasant surprise when you are around. We all need to be ready when the stage is going to be set. So, good evening, everyone. I'm Dr. Bharat Jagyasi, General Secretary of ICCM. And as you all know, it's an interesting session going on. So, of course, it's not a topic of the students. So, this is what I had a discussion with the Gunjan, because everyone in healthcare still doesn't accept AI. But as we all know, it already exists. And as Shweta has told us, we have gone from the predictable to the actionable AI. So, we will accept it only it becomes really actionable and we start using it. So, AI has an immense potential, as we all know, and it's a transformative technology. Abhijit is there. Abhishek is joined in. I
Yeah,
can
yeah,
see.
you can share
Yeah,
your
yeah.
slides, Abhishek.
Yeah, Abhishek.
Am I audible now?
Yes,
Yes,
yes.
Abhishek, very much.
Okay, thank you. So my screen is visible now.
Yes, yes, quite visible.
Thank you. Thank you, madam, and thank you, ICCM, for giving me this opportunity. So I will talk about now ethical challenges for AI use in the ICU. The disclaimer, so the images which I have used in this PPT, except for the scientific material, they are made by my text to image creation tool of the AI applications. So as Dr. Smita mentioned, artificial intelligence is a very good thing and it's transforming the healthcare, but it also holds the presence a unique set of ethical challenges that needs a careful consideration. If we talk about the ethics in medicine, there are four rules, as we all know: beneficence, non-maleficence, autonomy, and justice. So AI must take care of all the four things while taking care of the patients. So now talking about the patient autonomy, there are two important things: informed consent and decision makings. We all know when these AI-based models integrated in the patient care, there will be difficulty in taking the informed consent. How this the decision maker, this tool, that will be understood by the patient and the caretaker or not, that is a major concern. And the decision made by these AI tools, like as Dr. Suvita mentioned, it uses the black box algorithm, whether it is patients or not, AI in the patient care. So there is so much of view about this patient autonomy in the patient care when there is a talk about the AI incorporating in the patient care. Another concern about this patient care when AI is implemented, there is a patient privacy. So what could be the how this the data about of this patient it is accessible and use and control the patient data in private hands? How it will be handled by the private organizations? And there should be some strict guidelines to appropriately safeguard this data. And there is also one external risk of privacy breach through AI-driven methods. And the privacy preserving policies needs to be strengthened when we incorporate this AI in our patient care. These are the literature which mentioned about the this or patient autonomy and how to safeguard this patient's data. So this is there is one computer based technological this research publication which shows us the ways to safeguard the data of the patient care. Now then the concern about the accountability and responsibility. So if we talk about if we implement these AI-based models in patient care, and by implementing this, that there is some negligence or some mishap happens, then who will be responsible for this thing? This AI developer tool maker means these technologies, or the clinicians, or the hospital authority who implemented these. So there is a problem in taking the accountability and responsibility. And if we talk about another thing, another way of implementing these, whenever there is an AI-based models are there in our patient care, and because of the rigidity of the clinicians or rigidity of the hospital administration, that we will not use this and these AI tools. And if patients then happens mishap, then also the whose responsibility. So that needs to be identified while implementing these AI tools in our routine ICU care. So there must be clear rules. And if there are errors, then determining accountability of the four errors in AI associated decision making, it is quite complex, but need to be identified. There must be a legal framework. A robust legal framework is needed to address the unique challenges for AI in healthcare. Another concern is trust in AI. Sometimes when AI is situation where they follow AI advice without sufficient critical oversight, even when it might be inappropriate. So these are the challenges. There will be solutions, as Dr. Sweta mentions, clinical decision support groups may be helpful. Then transparency and concern about transparency and explainability. So as we all know, these AI-based models work on the algorithmic logic, or we can say that these black box algorithms, as Dr. Sweta mentioned. Now, when we treat the patients when the patients are treated by clinicians, and if some mistake happens, then clinician might be having some explanation. There may be concept, and they might understand. They might be able to make us convinced that this was our thought process, and that's why this treatment was given. So there is a scope of the improvement in the mistakes. But when these mistakes are done by these AI-based models, which works by the black box models, and there is no any transparency, there is no any clear-cut concept how this output was generated by this AI. So this is one major concern by implementing this AI care in our patient care. Then another is decision-based explainability. Patients have the right to know why an AI system made a particular recommendation. So that is the one other concern. And the trust and acceptance. Transparent and explainable AI systems can increase patient trust and acceptance. Another thing is now bias and bias in data and flows. So how these AI-based tools can create bias. So there is a publication in Curious. There is a nice publication of the use of artificial intelligence in intensive care unit. And they have mentioned one incident by incorporating AI-based models in unintentionally biased towards one race of the patient in giving the providing hospital resources in the patient care. And so there was an unintentional bias in giving the patient care. There can be some another bias which can be there by we will implementing this AI in our patient care. Because AI-based models incorporates data from our patient data only. So what is the major this hurdle in this? Many of our hospitals, especially in India, we talk about now, all hospitals are not digitalized. And even in single hospital, if 8 ICUs are there, 6 ICUs are following digital system, and the 2 ICUs are following the paper-based system. Now, how this mixed data will be incorporated by this AI model, and on this incorporating this data, and on base of this data, when this output is generated, how valid they are. So these are the concern and bias. So AI can also be racist. AI can also be sexist, like human beings, which need to be clarified. There may be a social and cultural inequalities. So there is a high possibility that AI can exaggerate these social and cultural inequalities. And there is also one concern in complex issues like end-of-life care. How this AI will be useful, or AI will be effective, and how this will incorporate the data or take the input from the patient, doctors, and other and very effective outcome, which we usually do in the daily routine life, every intensivist do. Whether this AI-based model will be will be effective in the same way or not. That is one query, and that needs to be clarified. Another concern is data privacy. The patient data protection, how it will be protected. The sensitive medical information must be securely stored and used only with appropriate authorization. There must be some process of data anonymization, and there should be a strict guidelines for data access control. Access to patient data should be restricted to authorized persons only. Now, impact on the human or job displacement. So there is so much of noise. Whenever this AI will be incorporated, there will be so many loss of or unemployment of the doctors and healthcare workers. So what is that thing? How it will work when AI is incorporated? So the literature or the present literature or present publication suggests that so major impact will be on the radiological doctors or pathologist doctors or skin doctors. But if we talk about the US data at present, the job opportunities of the radiologists and pathologists are increased. But that might not be the true in every part of the world. So this is one other concern. Another concern is moral distress of the clinicians. So what happens whenever this AI-based model is incorporated in the patient care, and clinicians might experience moral distress. What happens? There may be conflict with the clinical judgment or ethical principles with AI recommendation. Like AI suggests treatment that may prolong the life without necessarily improving the quality of life. So AI system should always be subject to human oversight and review. And there must be some regulatory frameworks. Clear and effective regulations are needed to guide the responsible use of AI in healthcare. And there must be some human and AI collaboration. There must be they must complement, augment the expertise of healthcare professionals and not replace them. A clear role and responsibility of humans and AI system should be incorporated, and there must be a multidisciplinary approach involving technologies, healthcare providers, ethicists, patients, and regulatory bodies. So before I conclude, this is the three laws of robotics, which was given by Sir Isaac Asimov, who is considered the pioneer in robotics and who had mentioned this robotics in the history for the first time. So he proposed three laws of the robots and later added the zero law, which stands true for this artificial intelligence too in this patient data. The law one is robot may not injure a human being or through inactivation or allow a human being to come to harm unless this would violate a higher order law. And law 2 is robot must obey orders given to it by human beings, except where such orders would conflict with the higher order law. Law 3 is robot must protect its own existence as long as the protection doesn't conflict with the higher order law. So these are the three laws, and then later it incorporated the law 0, which is a robot may not it may not injure humanity or AI has potential to revolutionize critical care, but ethical considerations must be at the forefront for its development and implementation. Continuous dialogue, responsible research, robust governance are essential to ensure that AI is used effectively and in the ICU. Clear roles and responsibility of AI and clinicians need to be confirmed before implementations. Patient data security and privacy need to be taken care well, as well as the clinician's clinical acumen. Major hurdles in the implementation are convenience, training cost, patient hesitancy, etc. The final thing, will all AI replace ICU doctors and HCPs and make them obsolete soon? That will be discussed in the panel discussion. My answers will be no. And with this, I conclude my presentation. Thank you.
Thank you so much, Dr. Abhishek. That was quite precise and well covered. Can you stop sharing your slides? Yeah. So we go on with the panel discussion. For leading the panel, we have our moderator, the General Secretary of ISCCM and the Director of Reliance Hospitals at Navi Mumbai, Dr. Bharat Jagyasi, to take it forward. Your stage, Dr. Bharat.
Thank you, Gunjan. And as we were discussing to all the panelists, it's a important discussion to have it because we stand at the forefront of a new era of in healthcare, where artificial intelligence is no more a concept, but it's a reality and it's a beginning. And from, as we discussed, Dr. Chata told us, from enhancing diagnostic accuracy to predicting, now we are reaching towards an actionable artificial intelligence. And we, as a human being, has a tendency to start believing when we see it. So when it's actionable, we'll actually start realizing it. But in today's era, it does exist. So as with any of the technology, when there's a transformative change, so there are significant challenges as well. So those are ethical challenges, balance between human judgment and machine recommendation. And this is what we all look into, and we need to ensure how does AI augments rather than overrides our clinical judgment, and what are the ethical things we should be looking into. So to discuss all this, we are fortunate. We have an immense experienced faculty panelists. We are really working in this field. So and they will be guiding us through. So to start with, we have Dr. Asif Ahmed. Dr. Asif is head consultant and head of Department of Critical Care Medicine, Tata Hospital, Jamshedpur, and he is a very senior member of ICCM, teacher, and has many accolades to his name. Then we have Dr. Avnish Khare. He is the main lead in AI. He's a guy who was anesthesia, critical care, and pain management consultant. Now he's transformed his overall career into the AI. His main focus is on AI. So amongst all the panelists and all of us who are part of this webinar, Avnish Khare is the guy who's purely 100% working with the AI. He's certified American Board of AI in Medicine, and also members of many communities in AI. BrainX AI committee is one of those to be named in, and his top voice on the LinkedIn as far as the AI is concerned, and also featured in Forbes and Times Square as far as the AI is concerned. So he's a guy who's worked 100% with the AI amongst all us. Then we have Dr. Kamaldeep Yadav. Dr. Kamaldeep is very active member of ICCM. He's head of ICU Yashoda Hospital and Research Center, Ghaziabad, Uttar Pradesh, and he's pioneer consultant in Delhi ICU and instrumental in establishing emergency center at Indira Gandhi Airport, ensuring critical care readiness in those areas. Then we have Dr. Prashant Nasa, Delphi expert, a very renowned critical care specialist who's actually got, I would say, who's actually got Delphi into the critical care is Dr. Prashant. Otherwise, it was not known to the critical care. And he's working with the Royal Wolverhampton NHS Trust UK. We have Dr. Abhinav Gupta, who's a consultant intensive care and lead for ICU follow-up and ICU education, that is for both undergraduate and postgraduate Croydon University Hospital. So we have an extreme senior faculty. So let's start with the question. So my first question, Dr. Abhinav, it would be coming to you. That's the reason why I introduced in the last so that I can have you first on the questions. So what are the key areas where AI has shown the promise in the ICU? What exactly you are looking into?
Right. Thank you. Thanks for a kind introduction, Dr. Jigyasi. Nice to see all my colleagues back again. Thank you. So, nice, good presentations on AI, and the key areas that we sometimes it's interesting because there was interesting points that were raised during the presentations about AI being the master and AI replacing humans. I think first of all, the same questions were raised when we saw computers being involved, and look how we use computers now, and we are using computers to a fullest extent, which are helping us out. So AI we see in our day-to-day life, right? So I think most of us have used ChatGPT. We're providing immense education. So this is common to most of us actually, and I'm quite surprised to see even the school kids using ChatGPT now for their homework. So which is and from that stage to clinicians using ChatGPT for more information and for their day-to-day work. And this is one of the routine days, that is of clinical and non-clinical. But in our clinical scenario, we've seen patients, next generation ventilators coming up. I don't know if you people have worked with the Hamilton ventilators that have come, which is called as Hamilton CE. I think if time permits, we can discuss about there are challenges, but these are evolving ventilators, which is more of a comfort to the junior doctors and the nursing staff. You put the patient on ventilator, and they evaluate on the basis of compliance and resistance, and they automatically adjust ventilator support. Sepsis is another one thing. This year we've had the first US FDA approved sepsis AI being approved, which is the sepsis immunoscore, which is able to predict the prognosis and the ongoing sepsis within 24 hours of patient admission. The other sphere that we use is hemodynamic monitoring. We've seen Edward coming out with hemosphere monitoring, which to predict hypotension in this one. AI is from the clinical side going more into the non-clinical aspects. AI is being increasingly used in NHS. We are using AI in predicting the patient admission, allocating resources. Everybody is working on full capacities at the moment. So and so often we have patients whom we are not able to discharge from ICU. So AI is one of the first hospitals to use AI in NHS is Kettering General Hospital. They've used AI to find out bed capacity and patient allocation, which is quite useful in terms of reducing cost and predicting patient flow. Especially patient flow is based on historic data. They can predict patient flow. So these are some of the aspects where AI is being increasingly used in hospital. This just to mention a few.
So yeah, it's very heartening to know. I mean, you started from predicting AI, as you said, in the sepsis and predicting the patient requiring admission, and also you're using an actionable AI whether to decide whether this patient needs to be transferred out of ICU or not. So it's an early start, but of course there's a first step towards it, and we have started seeing now AI is being used in our deciding also, not only predicting whether how the patient is going to behave, but also it's helping us in the decision making as well. So my next question comes on this only to Dr. Kamaldeep. What would be the challenges? As he said, there's a first step always which has been set in. Of course, there's a small step where we can decide whether patient this needs to be in the ICU or can be taken out of. So what are the challenges in implementing AI in the overall ICU? How do we look into it?
Yes. I'll tell you my real-time example. I tried to introduce a centricity kind of algorithm in our system. Everybody was ready for that system. It was a predictive analytic kind of system. The thing is, we started adopting the system. The command came from the higher authorities that we would do it. We will digitalize all our system from cardiac monitoring to everything. So the engineers came from a very reputed company. What they did was they tried to install all kind of they tried to back compatible the system from all the monitors. The monitors were very old actually, and they were very good. They tried to take the data, but they were unable to. Then our message that we will invest more and you make it back compatible. Then they installed some other softwares. Then some more limitations came up. So there was technical and logistical barriers. So the time went out. It was 2-3 months. Engineers were failing. They needed more wires. So at last, then suddenly something came up like some accreditation, like NABH accreditation. So the engineers were exhausted, and suddenly everything was fading. Actually, everything was fading. So the thing is, the initial excitement and the potential can diminish because the AI encounter resistance from the established workflows, and there's a natural skepticism among the clinicians. So this we encountered. So, but I feel that the clinicians, apart from everything, they should learn about the main things. What are the deep neural networks? Like the basic that when the ventilators were started, we never know IE ratio, etc. Now we know everything. We tell engineers what to do with the IE ratios. So we need the basic things like gradient-based optimization, which relies on the back propagation, is a primary technique which is used to train DNN. Every clinician should know what is the gradient-based optimization. So we should know how to calculate the loss function. See, we should know how the DNN works. So if we consider a hospital as a living neural network, so think of each department in our hospital as a layer in a neural network. The emergency department, ICU, general wards, and administration are processing information, making decisions, and passing on critical data. So this happened. So the things can get, when the AI is trying to get implemented, things can get saturated. Not even saturated, things can get totally stagnated. So it was around 6 months have passed and nothing happened. So what is the solution for that? So DNN is our brain. It is a society brain in our personal lives, in our system, in our society. So in DNS, the AI, we know how to conquer this activation function. We use an ReLU, as Dr. Anvish know, we use rectified linear units. So these 3-4 things we should know: how the neural network works, what is gradient-based optimization. So we try to get take the positive parts of the AI first. So that predictive analytics, where actionable we can later on, but the very positive parts we should take on immediately and implement in our system.
Very nicely put up, Dr. Kamaldeep. An example is also good. So in earlier days, I think even before we were the residents or we were getting training in critical care, so anyone who was on ventilator, it was kind of a death. So there was a norm, ventilation means death. And the reason being was the drivers were not sure how to drive that machine. We didn't know how to drive that machine. So clinical expertise will come in only when we know the integrity of that machine. So without going details of it, as you spoke about the neural networks, and I'll not go into the details of it, but I'll have Dr. Avnish to have on board just to let us know what exactly the clinician needs to know about this and how do we train ourselves so that it's actually useful to us and help us out rather than troubling us. Dr. Avnish.
Thank you, Dr. Bharat, and thank you to ISCCM for inviting me to this stage. Being working in critical care in the past, it feels like home to me, and I have seen things at the front lines, especially during the COVID pandemic. So I would like to say that whenever a new technology comes, there's something called as the Gartner's hype cycle. The Gartner is a company which does consulting for many big firms, and there's always a peak of like inflated expectations. So right now, in terms of AI, we are at the peak because everyone is talking about it. We have not seen many successful use cases as of now in healthcare, and especially in critical care, but a lot of talk is happening. And after this comes the valley of despair. The valley of despair is usually the place where all the hype goes out, and then what actual use cases there that remains, and then we move on to the plateau of productivity. So what takes us from this peak of hype expectations to plateau productivity, I think the core piece of the puzzle is education. We are already aware. We are talking about AI. We are reading about AI, of course, from different sources. Most of the education online is free. It is available on different places. There are now some hands-on workshops which are happening. I am part of a community called Doctors AI, where we believe that artificial intelligence should be driven and it should be shaped by doctors, of course, who know about the technology. So we are conducting hands-on workshops with customized use cases. Like, for example, you want to use it as a research partner, or you want it to build your PowerPoint, or you want to use it for patient clinical decision support. So we hold these marathon workshops, like 6 hours. It's not easy to attend. So I would say that we need to have more customized solutions, as Dr. Kamal said, for physician education. One size will not fit all. There will be some people who would just like to be informed end users, and most of them will be in that domain, while some will go on to become developers of solutions or builders of solutions, and they will definitely need more education around programming, around coding, and all those things. So, while some will stay in between, like I consider myself somewhere between a developer and an informed end user, and they will also be educating other clinicians. So I think it is very important. First point, there should be huge emphasis on education for clinicians. If it is from other clinicians, then it is even better, because we as a community, like it has been tradition of clinicians teaching other clinicians on whatever developments are happening, and that is why we have conferences and CMEs. So I think more and more such activity should happen around artificial intelligence. This event is is a part of like the same initiative. So we need to further this, and then we need to have customized solutions, as I said, and continuous learning. The continuous learning is very important because this field is very dynamic. What I learned 1 year ago related to AI is already outdated, and I have to keep myself abreast with the latest developments which are happening. Like ChatGPT came out, and then everything changed suddenly over a period. We were talking about deep learning and neural networks and all those things, and suddenly everything focused on generative AI. So we need to be ready about those things. We need to be agile. We are a bit late, I would say, in healthcare to especially learn about AI, but still there's time, and still we have the opportunity. And students, I think whoever is listening to this webinar, if they are students, they are going to be practicing for next 40, 50 years down the line, and it becomes very, very important for them to start learning about AI. So I think educate, and educate. That would be my message to everyone as much as they can.
So rightly said, but there's a problem also. We don't understand how do we integrate AI with the clinical expertise, and how can AI complement clinical decisions. So we need to achieve a right balance. So what are the tools we should be looking into? Should be the user-friendly, easily interpretable by the ICU teams. So how do we start using it, or how do we start looking for those tools? If you're aware of something, so that it brings out the interest in the students, this is how we can use it. Yeah.
Definitely. So before 2021 November, we were talking mostly about data-driven AI, where you needed to know Python, and you need to learn tools like Orange, and then you have to experiment with your data to build some sort of AI. But after that, we have some things coming up under generative AI, And generative AI, what it has done, it has democratized AI, and it has brought tools into our hands of entire population, not just clinicians. So the best way to learn something is to start experimenting with it. I would not say that go and use ChatGPT tomorrow to decide whether you want to extubate a patient or not. That would not be the correct approach. Start with low-hanging fruits. Start with automating the drudgery, as they say, your routine tasks. Maybe building a PowerPoint. Maybe just summarizing news articles to consume them. Maybe writing an abstract for a journal article that you are writing for. So start at those places which are low risk and which are not going to harm the patients. And as you gradually start using those tools, you become more comfortable. You along with that, you're already doing continuous learning from different sources, so you get used to the terminology. Actually, mainly what we are afraid of and we fear is terminology like deep neural networks and generative AI and artificial neural networks. These terminologies make us more afraid. This has been my experience when I'm teaching students about AI. Once they have those things covered, then they're very open to explore the tools which are available. There are a lot of tools. If you go online, there are some websites which are having directories of tools of generative AI. So you can just go and Google and start using those tools. See, we are talking about clinical decision support, which I think comes very much like downstream. We need to start with automating our administrative tasks. We need to get free time for ourselves so that we can then explore those tools for patient care. So I would advise start with generative AI tools like ChatGPT, Perplexity, Gemini. These are available online. Glass Health was a very good tool which was shown in one of the presentations. I would say that if you have to even buy a subscription, buy it for some time. You can, most of the tools have monthly subscriptions. Use it for educating your students. Use it for cross-checking your clinical decision making, whether you are doing it in the way that it is telling or not. Then, of course, to use your common sense. Don't lose it in using these AI tools. Always remember that you have the autonomy, or you should carry that principle, which 4 principles Dr. Abhishek showed: beneficence, non-beneficence, autonomy, and justice. All those 4 tools, all those 4 principles should be not violated in any tool that you use for patient care. That should be the primary aim.
Thank you, Dr. Avnish. Dr. Asif, now I'll come to you. Dr. Avnish has very nicely explained it to us, the technical aspects of it. Now, if you have to tell me as a critical care expert, how do we use AI in critical care? What are the areas we look into, we should be pitching into, and we are using it, we all know it. So if you could appraise us about those things, how useful is going to be in critical care? What is the future ahead as far as the critical care is concerned?
Yeah, thank you, Dr. Bharat, and thank you to the ISCCM team basically for having this topic taken for a panel. And I think we have heard a lot about it. I hope I'm audible. Yeah.
Yeah, you are audible.
Oh, thank you. So when we talk about the application, as Dr. Abhinav started, like how did we start the use of a computer initially, how we have gone from the days, from the years, and how we are right now. So similar way, at this present particular point of time, there might be centers which have really gone to the peak of usage of AI all across the world. But there are also centers who are still in the stage where they are not at all aware about it. There is a lot of ambiguity, there is a lot of uncertainty, and it's a very gray area for all the people who are actually talking about it. And when we talk about implementation or application in the ICU on patient care, the first important aspect is that the people who are supposed to give this care, the medical professionals, I think there is not much of knowledge spread that has been there. A lot of awareness is still to happen. That's on one part. But when we talk about the application in a critical care setup and its safety in patients and its implementation, I think the baseline is that no doubt AI is going to be something great. It's an excellent phenomena for today and tomorrow, and all of us are going to use it in the coming of times. But we also need to understand that the application happening at the bedside or at the patient level, we saw all the parameters which were there about the application, talk about its accuracy, reliability, the prediction, and everything about. So there again, you always have a flip side. You have the good things, you have the bad things around. So no doubt it has helped us in a lot of predictive models, as helping us in diagnosis, and also somewhere it has been able to guide us. We have never gone to the actionable AI till now. But even if we talk about accuracy and reliability in our patient care, how is it practically possible at this point of time to go ahead? Maybe we might have it after 2 decades from here, but we have already worked about it 2 decades beforehand, a decade beforehand, where a lot of data has been taken. We have created this AI model, but these data are all based on retrospective data. These are on limited numbers. These are based on focusing on small clinical areas. We have never talked about a prospective data, or we have never talked about having it taken as a prospective study or as an application, when we have talked about overall application for total patient care or clinical examination and treatment. The sample size, we don't know. We have picked up data helping in nutrition, helping in ARDS, predicting about cardiovascular disease. We talk about everything in the ICU. But what's the sample size that is adequate? We don't know. It was insufficient. What's the validation of this data? That's important. We might have data picked up from center A, and we apply it in center B or center C, where the patient mix or the different points of entry have been very different. I think it becomes very difficult for the application as such. I think these are points which we have to always keep in mind whenever the application comes about in the future. And no doubt, the inconsistency of the data, if we feed wrong data, it's already documented and has been highlighted many times. You have a rubbish in, you get a rubbish out. So you feed in whatever type of data, that's what's going to come out. We do not have a transparency, a lot of bias that we saw about what type of data that we were talking about. And then the unpredictability, then your accountability and the acceptability, that's another problem, because what is the ethical barriers that are around? I think it has been touched upon. We talk about the patient data. Now, we have taken data, we have been able to whatever has been allowed till now. But what, based on the Digital Data Protection Act, how is it going to apply in the coming of times? Where at one point of time, we're trying to get very conservative with it, and at other time, we are trying to get all this data uploaded and trying to get a base out of it. So I think these are the major challenges which we have to apply. And in fact, it's about prediction now. We also need to see what's the role of an AI tomorrow or today? Is it only going to be an aid or a support, or is it that it's going to become an autonomous or a decision maker in that aspect? I think it has to be very clearly noted down, because here, then you have the legal governance, then you have the accountability, you have a lot of other issues which can come about. And as I said, what about cybersecurity in these issues? What if data is hacked, or what if we have outages like the one that was just spelled out by Dr. Shweta earlier? So what are the backup plans for these? You at one time try to get down with all the support in terms of the manual or the manpower support. We are trying to make it more mechanized. But if everything fails, what is the backup plan for all of us? And as already said, I think the high cost, the empathy, the human touch, the applicability and availability of these in terms of the cost and spreading it all across the different subcontinent, that would be a major challenge as I see as of today. I think these are not deterrents, these are not the negative aspects, but these are the challenges, or these are the concerns which will always be lingering. And it's important that all of us have to address one by one. And we need to see how, with whatever knowledge we talked about application across the different subcontinents, different areas, how easy we can make it for the times to come. I think these are the practical aspects, Dr. Bharat, which would really always
very
come at the back of my mind.
nicely elaborated. I mean, the important point was is basically totally output dependent, and if we have the rubbish in, then the output is also going to be the rubbish. And you also raised the important concerns about the patient safety and ethical. So I would like to pitch in Dr. Prashant also on the same thing. Of course, it's a totally data dependent and input dependent, and we have the ethical and legal considerations as well. So what is your take on that, Prashant?
Thanks, Dr. Bharat. And I agree with a lot of concerns which were raised by my other co-panelist. But yes, as said by another panelist, Dr. Abhishek, Dr. Abhinav, that it also depends on how the technology has evolved. We have seen that concerns when mobiles came up, that there will be ethical challenges, how to save our data. But these days, mobile has become part of our daily life. The same way, artificial intelligence is coming up. So of course, there will be ethical challenges. There will be a lot of concerns related to the data. Besides what Dr. Asif mentioned about how to save patient confidentiality, how to make sure that patient confidentiality is not breached. There is always a bigger concern, which I believe working in India, or probably the data which is coming up from most of that, at present, artificial intelligence, the most of the input data is coming up from the Western countries, from Europe and North America. And we know the biases which come up in even in those data, we understand that talking about North America, the representation of healthcare data is only 10% coming from Black community versus when it comes from the white community. Just imagine the same thing is not being represented at any level from an Indian setting. So if there is a machine or algorithm which is coming up probably in the future as an actionable AI do not have a representation from an Indian setting, will you be able to implement the same AI in your ICU? I don't think so. So it's important that we understand these ethical challenges and at the same time embrace technology in the same perspective. So I think the first step while working in an Indian health setting is to have your data electronically available, to take research on that particular data, to develop an output coming up from that data rather than coming up from a Western world only. I think that's one thing which need to be ensured. The other bigger challenge is equity. Considering the so-called the history of this planet, most of the resources have been limited to a very few part and with very few people. We should take these resources to everywhere. And I think this is the time where this resource limited world should take a stand, should make sure that the newer technology become equitable to everyone. The third and more important, I think, issue is about the legal part, which Dr. Abhishek presented very nicely in his presentation. There was a lot of things he highlighted related to how this black box and these higher tech companies are going to make sure that the technology which is being used is easily available. Most importantly, it's transparent. We really don't know how these machine-based algorithms are working right now, how they are analyzing input data. We only know there is a limitation that how much deep neural network can understand this. Even there is no understanding what is available to general public and to an extent to even to experts like Dr. Avinish, that what is all happening within this deep neural network, how this thing is coming out. So we need those challenges to be sorted out before these things will be embraced. But as I understand, these are initial hiccups which we are seeing, as he rightly mentioned, that this is a time where there is a lot of noise. We are understanding there is this noise will be expected because there is so much hype which is coming up. There are new companies which we have not heard a decade back has become now comparable to Microsoft and Apple. We know Nvidia has become a big hype company now. But this is after this hype and after this noise, there is definitely, which is much more, we will see a clarity coming up from this technology. And I believe that as like previous, previous technology, this will also become part of our life. We need to embrace, we need to pivot, we need to keep our eyes open, our ears open, but make sure that this noise is no more a clutter. This noise always give out some clear messages, and that's the reason I think we should be much more aware, we should be much more advocative, and at the same time understand how, being in India, the way we are saying the next century will be for India, how we should work together with people from West to make sure that the resources are available not just to them, but also resources are available to us. At the same time, this newer technology take data from our part of the world so that they understand the challenges and the complexities, especially related to the healthcare, especially related to the genetics, and that output become much more important for us also.
Yeah, thank you, Dr. Prashant. I mean, there's so much to talk on this. It looks like we just initiated the discussion and still it's a warm-up session. But I think we have passed our time. So what I'll do is I'll request each of the panelists to give us just a one line how it's going to be useful in the critical care. To start with Dr. Abhinav. Yes, he's raised his hand as well. Dr. Abhinav, please.
I raise the hand basically because just to add on to one of the things that we generally face is are the patients aware that their data is being used for AI, and who's using this data? I think this might pose a legal challenge in Western countries because of patient's autonomy. So one thing that I would want to highlight in whatever was going on, basically.
Your take, yeah. How it's going to be useful in critical care, whether yes or no, it's going to be useful or not.
No, it is very useful in critical care, basically, because we have started using the AI generated information from large patient data. Because as of now, until now, well, we've been working in critical care for a long time. We've been using evidence-based medicine, which may be applicable to certain sections of society. But considering there's a large data set combining with algorithm, and that is generating enough information and generating protocols, which is very helpful for use in critical care. And we've been generating, let's say, as I said, that we are working with the ventilators, the AI next generation ventilators, which automatically adjust the ventilator support. We are using the predictive models of the AI-based scenario to predict the mortality and to predict the morbidity in patients, especially with sepsis and liver transplant patients who are coming to ICUs now. We are working with the predictive models, like Edwards have come up with the hemodynamic monitoring to predict hypotension in patients who are already there in ICU. And we are using, we've seen extensive use of ChatGPT in discussing with patients and generating information for documentation purposes, for discussing, for generating enough knowledge to be passed on to the patients. So it is very much a part of our normal routine day-to-day working. We have alerts coming up on the system that, okay, the levels are high, drug levels are high, please change the drugs. So this is very much a part of our critical care based system, and to present information to patients to help us in clinical day-to-day management of the patients, and to, well, the next thing is to personalize treatment. I'm not going into that, but even the managers are using it for maintaining the flow of patients, on predicting admissions and to predict where the patients would go. So it is a part of our system. It cannot be said that it is away from us. We are incorporating more and more AI into our day-to-day clinical scenarios and management scenarios. So yes, it is very much a part of the system.
Yes, Dr. Kamaldeep.
Yes. Just in one line, as Dr. Prashant has earlier said, we were afraid of mobile. If we think ISCCM as a neural network, let's filter out the noise by allowing only the positive, useful signals to pass through our network, so that it helps our ISCCM stay focused on what's important, so that we can learn more effectively, actually. So focusing on the positives and blocking out the negativity. That's how we learn.
Dr. Avnish, how is it going to be useful in critical care?
So I learned a lot in this session, and thank you so much again. The thing I would like to end with is just 2 quick points, not one line, but 2 lines. One line is that if you want to identify use cases in any particular field, I would recommend this even for beginners who are new to AI. Just try to find out use cases where you either need to predict something or you need to classify something. And now with generative AI, if you want to generate something, generation means either patient notes or any other sort of thing. So just keep these 3 things in your mind as an umbrella, and then try to identify places in critical care where these 3 things are happening, and then use AI for that. And second quick point, which Dr. Prashant's point just reminded me, is that we need more and more data from our geography. So, and this starts not just with electronic medical records, it starts with data literacy. So we need to have a much more data literacy in our part of the world. It is already there in Western part, and that is why they have a huge amount of data as well. So let us build more data literacy among ourselves as clinicians, students, everywhere. We should, each data point that we enter into the systems, we should consider it as a food for something down the line, which is AI, and it will be again used as a feedback loop to improve patient care. So that should be how we should do it, and more anonymized and data sets, more and more geography specific data sets. Let us create those as part of ISCCM. I would like to suggest to create more of those. Thank you.
Yes, thank you very much for it. Prashant?
Thanks, Dr. Bharat, and thanks ICCM for taking this topic for change. I think beyond our routine critical care topics, it was a new thing. I think both of our thoughts have worked well to create this webinar. Probably this will be one of the first webinars to talk about AI in critical care in India. I think this will change the world. To the end, I would like to add 2 famous quotes, which are not my quotes, but I read during my understanding of AI, which are also from 2 major experts. Artificial intelligence is not a substitute for human intelligence. I believe it's a tool to amplify human creativity and ingenuity. And really, another 2 quote which I really liked about AI is, it's going to change the world. Whatever we say, it's definitely will create a new history for humanity. And this history will be even bigger than the history of the electricity.
Oh, that's a very positive quote to have it on to end with. And Dr. Asif, I missed you, yeah.
Yeah, no worry. Just thank you so much, Dr. Bharat and all team members. Quickly, I won't take more than a minute. The first thing is that there is a change. We have already seen the change happening. It's the need of the hour today, and we're going to have it in the future. No doubt about it. That's the baseline. Now, two quick things that we would like to just address. As I said, I think we have to look at how the execution happens at the ground level, where people are going to apply it. That's very important. It's not that we want an AI at every place tomorrow. But whenever we have an AI, the processes have to be right. The landing has to be very good so that once it's in there, I think every application then becomes easy. So rather than focusing on just to have it, I think it's very important that we look into the different intricacies as to how and what are the problems and the concerns, how do we address it step by step. And if we get those processes right and the approach is good, I think it should be no doubt a big boon for all of us. But no doubt, this is something which has to be always kept at the back of mind. Yeah. Thank you.
Thank you to all the panelists. And now, Dr. Gunjan, it's over to you. If we have some questions, Abhinav has raised the hand. Yeah, Abhinav, please.
Yeah. So, sorry, I think it just suddenly struck me basically when I was reading the thoughts of Prashant and Asif. So it's interesting basically because I don't know if how many people participate in the datathon that are organized. So a lot of societies, not only European society, a lot of the local societies, they organize datathons. And datathons are, you work on large set of data that are given to you. And we generally work in teams. The teams are comprised of clinicians and statisticians and data analysts. And this is becoming very common now. And I would strongly suggest that it would be very useful, as you mentioned about critical care scenario in India.
We thought of this around a month back, but to be very frank, I mean, we brainstormed to it.
The bigger limitation for India is to have a registry. I think, it's a registry which is not there.
Yes.
Yeah. So it not only inculcates thoughts, even if you give a small data set, but inculcates people to read more about Python, read more about AI, and to think about more in terms of AI. I've actually started reading more because I participated in last 3
It was very widely discussed in our guideline committee meet to have on this.
Right. Yes. Right. That's good. Just let me know. I mean, I'm happy to help.
Yeah. Thank you. Gunjan?
So we have 2 questions from the attendees. One question is how far we should use technology for teaching purposes only, or everything like to take care of the patient? I mean, how far? I mean, any of the panelists can volunteer. So
I think at present there is we are really far of asking a chat GPT how to treat a patient. Please do not do that. Even if you have heard some of us saying that, please do not. So this is at present just to be aware what is all happening in this sphere. So next time, do not go to a chat GPT to talk to you, to talk to your patient or to treat your patient. That is really far. Of course, you will get some answers. And there lies a big dilemma, whether to take those answers for you for treating your patient. No, definitely no. So this is still an evolving phase. Keep your eyes and ear open, what is all happening, and take this noise, filter out this noise, what you should be using. More importantly, you should be aware about what we have talked about, what all concerns we should be having while embracing AI in our use. And most of the research which is happening is picking up this into a predictive AI. We are still far from actionable AI, at least in critical care setting.
Can I say predictive AI is very useful? So basically, because we are using predictive AI in our day-to-day life, is to predict the mortality, and it's very useful to inform the patient's relatives about what are the chances of survival and mortality. I think it is something. It is an aid memoir to a lot of things that we generally use in our clinical day-to-day setup, and to inform the patients and their relatives, because everybody can Google now, and we can provide a bit more information than what the standard internet would provide.
So yes, that's my take. You want to say something?
Yes, Avnish wants to say something.
Yeah. So since it is about education, so I think the answer is in the question itself. You start with teaching, and then when the tool is mature enough, you go towards the patient care when you are quite confident and the legalities have been sorted out maybe in the next few years. I have seen examples where Glass Health has been used by some teachers in US to teach students about the correct approach what they should have for the patient. But then when they go to the patient, they should apply their brains and then they should do it. Second use case can be to use tools like Perplexity, which give you sources from where they have taken the information for improving your knowledge, which again will translate into patient care down the line. So we cannot have a very fixed like a line or a wall that this is teaching and this is patient care. I think it translates from teaching to patient care gradually. That is how I would say.
So working with AI, Dr. Avnish almost predicted the next question. So we are also live on Facebook and we have this question on Facebook Live. So the question is, how valid is the AI generated medical decisions in the court of law? How valid are these?
If I can answer, yeah.
Yeah.
So if I can answer, yeah. So no doubt, we talked about the validation of the very sources also of the AI. That was also questionable. That is still questionable. And a lot of work is to be done about it. And nobody has an answer to this. As of now, we have the legal governance for software, but we never have a software integrated into Medicare and the application of AI into medical care. So I think this is one area again where we'll have to get the governance and get the medical legal aspects, in fact, modified, or we have to have it generate. Then only it can be easy for all of us to practice. I think that was my opinion about it. Anyone?
So yeah, Dr. Avnish.
Yeah, just to add, see, generative AI has a very big problem that the answer every time differs and there's a lot of unreliability, hallucinations. So what is happening in some research labs is they have made tools for human validation of those answers. One of the tools is called Humanely. So what they do is they have a questionnaire where they test the chatbot or the generative AI tool across different scenarios or cases, and then they rank the answers according to different criteria, whether it is safe, whether it is harmful, whether it is relevant, whether it is complete. So we need more and more such human validation frameworks for the tools which are coming up, because these tools are very dynamic. They are very different than the technologies that we used to regulate before. And even FDA is finding it difficult to regulate these technologies. I think human in the loop, what we mean is that humans should be there to evaluate and validate these technologies, and that is where peer-to-peer education, peer-to-peer confidence, peer-to-peer trust, that matters. And I think we should talk more about these peer-to-peer validation tools for the tools which are coming up in future. That's just a thought.
So there are some, I think, governance policies which exist in various countries for AI. Like in India also, ICMR has prepared some policies and some guidelines for the legalities. And I think US FDA also has some, but I guess US FDA, I also read somewhere mentioning that as soon as they prepare the policies, the AI has already advanced much ahead of what the policies can justify or control it. So this is what I read somewhere online some time back. So yes, AI is expanding very fast. And I think we'll close the session here. And I want to thank all of you all again for being a part of this discussion, and having a view from all around the globe was really helpful. Thank you so much.